afternoon, folks. This is going to be our lesson on anatomical terminology. If you are following along with my handouts from the Blackboard site, you might want to keep the anatomical terminology handout available so that you can follow along to get the exact spellings of words and see some handy diagrams that may help you out in following with the things that we're going to be talking about here. I may occasionally type some useful terms into the chat, but nonetheless, for following along with the things that we're doing here, you might find that to be useful. But let's begin. Now, the field of anatomy and physiology, and going along with this, the field of medicine, have long had a terminology, a language of their own for consistently discussing what is going on in the human body, where body parts are localized, regions of the body where things can be found. And this is really important, not only for making sure that we're consistently describing the complex arrangement of parts in the body in a way that other anatomists and other medical practitioners can understand, but making sure that we can easily localize where an injury might be found, where a pathology might be found, so that when we are trying to describe something for patient care, describe something for research, that we consistently know what we're talking about. And it might sound like the terminology of medicine is deliberately arcane. It is, in some ways, it is deliberate, but not to isolate this from everyday language. Okay, yes, it is to isolate it from everyday language, but not for any elitist purpose, but more so because everyday language can be ambiguous. By trying to use a very precise terminology in anatomy and medicine, we're trying to make sure that we're defining as closely and realistically and precisely as possible where things are found in the body, what parts we are talking about, and how we can localize them so that anybody else hearing the description we're using knows exactly what we are talking about. And for that reason, we use words that are different than the words we use in everyday life for a lot of our anatomical and medical descriptions. Now, sometimes we are using the same words we use in everyday life, but sometimes those words have different meanings. For example, the use of the word arm and leg in anatomy is not exactly the same as it means in everyday life. This entire structure I'm waving around right now is not my arm, not anatomically or medically. And we're going to talk about why that would be different a little bit further as we go along. Now, a lot of times, we're trying to devise also a universal language for anatomy and physiology, something that will apply regardless of where we are coming from, something that physicians and scientists talking about the human body, no matter what their country of origin, would understand. Because of the historical origins of the biomedical sciences, at least in the Western world, coming out of the ancient Greek and Latin medical traditions in classical Greece and later inherited by the Romans, and how there was a very long-standing tradition in the Western world of writing scientific and medical manuscripts in the Latin language or in ancient Greek writings. Much of our terminology is rooted in the Greek language and later in Latin. So a lot of our terms are derived from either Greek or Latin. Greek was the original language of classical medicine, so much of our medical terminology actually comes from Greek. Some terms are derived from Latin, but Greek is, in many cases, the language from which our terms originate. And here's an important tip you can use. When you're learning many of the terms that we use in medicine or in anatomy and physiology, and you see these words, and they seem like they're big, long, complicated, unfamiliar words that you don't use much in everyday life, it can be easy to get overwhelmed by them. And say, okay, well, that's a complicated word I've never heard before. My advice to all of you, when you're learning these terms, is learn the parts of words. Learn the roots from which the words are derived. Learn the prefixes at the beginning of words, the suffixes at the ends of words, because if you can learn the parts from which the words come, you can build a word. And you can say, all right, I know that word part, and I can sort of figure out the meaning of an unfamiliar word even if I haven't necessarily heard that word before. So if I give you a word you've never heard before, and I say to you, for example, osteosarcoma, and that's like, okay, I don't know that word, but you know that osteo means bone, and you know that anytime you see osteo, it has something to do with bone, and you know that sarcoma means abnormal cancerous growth, then you know that osteosarcoma is bone cancer. And if you have learned those word parts, you can build that word. And I think this is an important tool that you can use for learning literally anything in the biomedical sciences. Learn word parts, and you can build any word you want. If you hear cardiomyocytes, and you know that cardio is heart, myo is muscle, and cyte is cell, then you know, without me having to tell you, that cardiomyocytes are the cells of heart muscle. You can build that word. This doesn't work for everything. Some terms have more obscure origins or more peculiar meanings that are a little harder to derive or come from some other source. My favorite example, kind of an amusing one, comes from the origin of the word testicles. The word testicles, which comes from Latin rather than Greek, translated from Latin, the word testicles literally translates as little witnesses. You can guess the origin of that meaning. And sometimes words in anatomy have other origins. The word acetabulum, there's an odd one. Acetabulum is the name for the cup-shaped depression in the hip bone, which is where the joint of the thigh bone connects with the hip bone. And the word acetabulum for that cup-shaped joint where the top of the femur, the thigh bone, connects to the hip bone, means vinegar cup. And you might think, okay, where the hell did that one come from? Acetabulum, the name of that one, comes from the fact that the ancient Roman physician Galen, when he was looking at that joint in the pelvis, looked at that sort of cup-shaped depression and said, that looks like the little cups they give you in Roman restaurants, in which they give you a little bit of vinegar as a condiment to put on your food. And that those little cups were called acetabula because the Roman word for vinegar was acetum. So acetabulum, the vinegar cup. And so sometimes you get weird little origin words like that that are not necessarily as immediately descriptive. I should also like to point out one more thing about anatomical terminology. Well, two more things. One, you also get words that are named after people. There are a lot of parts of the body that have a name that is after the person who discovered a thing or who first described a thing or named in honor of a great anatomist or physician. So you'll have things like Wernicke's area of the brain, for example, or the Purkinje fibers in the heart, which attach the heart valves or things like that, and when you get things like that, we're trying to move away from that. We're trying to move away from naming things after people in the human body. That's called eponymous naming when you get that. Partly because it's less descriptive. It doesn't tell you anything about a body part to hear that it's called Wernicke's area of the brain, except to tell you that Carl Wernicke discovered it, which is a nice way to honor Carl Wernicke, but, doesn't actually give you as the student any useful information about that region of the brain. And also, because we're kind of trying to decolonize medicine a little bit, it's not really helpful to anybody to have a lot of parts of the body that are named after a bunch of old dead white guys when they're literally in every single person's body, regardless of their origin. And so we're trying to move away from that practice in medical and anatomical description and give things more descriptive names. And not every part of the body that has an old eponymous name after a person has a newer descriptive name. In this class, whenever I come upon a name like that, if it has an older name after a person and a more modern name not after a person, I will give you both of them. In most cases, both names are in usage in the medical sciences, and unfortunately that means you kind of have to know both of them because you'll hear both of them. My preference is that you know and you use the more modern name. But in actual day-to-day medical practice, you'll hear both of them being used. So that does unfortunately mean you have to know more than one name for certain body parts. And sometimes certain structures in the body do actually have more than one name that is used. And the reason for that is also because medical research is being conducted in a lot of places in the world at once by a lot of scientists and a lot of physicians who have been doing their research over many years and many centuries. And there's not one committee that all gets together and says, okay, let's name this body part X. The terminology of medicine has been built by consensus over long periods of time, over many centuries. And sometimes that means we've all kind of converged over time on a commonly well accepted name to describe a body part. But also sometimes that means that people in one area have gotten used to calling a body part one thing, and people in another area have gotten used to calling it another thing. And that might mean there are two commonly well used descriptive names for the same structure. And if that's the case, I will note the fact that there are two commonly well-used descriptive names for the same thing. And sometimes that does mean that when you're learning the terminology of anatomy and physiology, you have to learn to use more than one name for a thing. And if there is more than one accepted name for a body part or a body process or whatever, they're all correct, you know? And if you give me an alternate name on a test for something and they're both valid names, I will accept any valid name for that structure. So there, I apologize. There is nothing we can do about the fact that the terminology of the biomedical sciences is complicated and overlapping in this way. That is an artifact of the history of how the field came together piecemeal, little bit by little bit, in many different areas over long periods of time. And we're going to do the best we can with it. There have been efforts made to standardize the terminology of anatomy and medicine in recent years. But again, it's work that's being done by literally millions of people in hundreds of countries around the world. And it's hard to come to one unified standard, especially when old habits die hard. And many doctors and many scientists are used to the way they have named things over long periods of time. But I will do my best to help you guide through it. Okay, where do we begin with all this? One way to begin with talking about anatomical terminology is to talk about how we discuss the body to explain it. How do we describe what a typical human body looks like? And here we need to say another thing. There is no such thing as a typical human body. The work of anatomy and physiology is the work of trying to say what is normal about human beings, when in reality, there is no normal. You need to understand this, that we're trying to establish averages for a species that has a wide range of variation. You are a member of genus Homo, species sapiens, Homo sapiens. You've all heard that term. And that's not plural, by the way. One of you is not a Homo sapien. You know, the S is just part of the word. And Homo sapiens is a widely variable animal with a lot of different kinds of features. But historically, research on anatomy and physiology has almost always, until very, very recently, been dominated by scholars and researchers and scientists and doctors who themselves were mostly white men. And therefore, there was a bias in their research where they assumed that what was normal for white men was normal for everybody. And therefore, when they were talking about what was the normal pattern of a human being, they were assuming that what was normal for themselves was normal for all humans. So when you hear about normal averages in anatomy and physiology and medicine, most of those numbers were calculated and measured and figured out using white dudes as the standard. And it was honestly, I wish I was I wish I could tell you differently, but it was really only within the last 20 to 25 years, only really towards the late 20th, early 21st centuries, that the medical sciences began saying, well, let's back up for a minute and start thinking about whether our standards might be a little bit off because we haven't been taking more diverse populations into account. And maybe whether we should be thinking about whether, things like the average proportions for a human body or the average temperature or the average blood pressure or even what the standard symptoms for certain diseases are would look like if we started taking into account a wider sample of humans that included more diverse populations or more women or anything like that. And it turns out once you begin broadening your sample, a lot of what medicine took for granted isn't quote unquote normal. That it turns out average human body temperature is not 98.6. And by the way, we shouldn't be using Fahrenheit anyway. Celsius is the standard. It turns out that average human blood pressure, when you broaden the sample, is not 120 over 80. It's closer to 120 over 75. It turns out that the reason heart attacks get reported more often in men than in women is not because men are more prone to heart attacks like we believed for a long time. It's because the symptoms of heart attacks are different in women and they just weren't studied as much and therefore they're underreported in women. So I want you all to keep in mind that when I am telling you in this class and when you are hearing in any medical class about the average proportions of a human body or the average statistics of anything, or that most of those numbers were figured out using white men as the standard. Humans are highly variable. And when you're going into average patient care, keep in mind that what is normal according to your textbooks may not be normal for your patients. Even for your patient being a white guy, there's room for variation. What I'm going to be giving you in here are, you might say, baselines, statistical averages around which there is almost always room for variation. Some things about humans don't change. We all have a four-chambered heart, for example. That's a thing that's normal for humans. Some things about humans you can expect variation in. I will give you some sense of where you can expect variation and where you cannot. Most things that have a number attached to them, like body temperature or blood pressure or whatever, you can expect a range of variation. And you have to get to know your individual patient and find out what their norm is. And if your patient tells you, yeah, my temperature always reads a little bit low, listen to them. And sometimes there's a clinical reason why, that maybe they have something health-wise going on that makes their temperature read a little bit low. Or maybe it's just that their personal body is a little lower in temperature than the average, and for them, that's normal and healthy. Keep these things in mind. But we have to start somewhere. And the starting point that we start with for talking about anything in human bodies is what we call the reference man and the reference woman. Reference man and reference woman are kind of an abstract average human body that we use for modeling what you might say is the average human. Keeping in mind that we are still figuring out what an average human looks like because we're still refiguring our numbers in medicine after centuries of assuming that a white man was the average, we still have some idea of what a quote-unquote average human looks like that we can use as a starting point. And the reference man and reference woman are that kind of normative starting points. In medicine, the reference man is sometimes defined in anatomy as a healthy adult male in approximately his mid-20s with an average height of approximately 170 centimeters. That is about 5'7", with an average adult weight of approximately 70 kilograms. That is somewhere around 155 pounds. Living in a temperate climate with an average Daytime temperature of about 20 degrees Celsius, in other words, around 70 degrees Celsius. Engaging in light physical activity on a regular basis, and consuming on average about 2,800 kilocalories per day. And if that sounds like a lot, keep in mind that in America, most of us do not move around nearly as often as in most places. The reference woman is similarly a healthy adult woman in her mid-20s, engaging in light physical activity, living in a mean ambient temperature of about 20 degrees Celsius, except a little bit smaller in body size, averaging about 164 centimeters in height, weighing about 58 kilograms, that is about 128 pounds, and consuming about 2,000 kilocalories per day. If that sounds small, keep in mind we are averaging out global populations around the world. And this is meant to represent, again, a statistical average human, with plenty of humans higher than that, plenty of humans lower than that. This is meant to be a statistical mean. Not to say, okay, this is what a human should look like. Not to say this is a quote unquote normal human. Not to say this is what a human should strive to look like. This is just meant to say this is kind of an averaged out, quote unquote, middle of the road human being. This is not meant to say this is what a healthy human looks like, and anything outside of that is not healthy. This is, again, just kind of a averaged out midline baseline human. Whenever I give you statistics for any parameter of a human being, and I say, okay, this organ weighs this much, or is found in this part of the body, or whatever, I am giving you the statistics of the reference man or reference woman, unless otherwise stated. Assume that every single number that I give you in here is variable. Assume that every single number I give you in here is variable for a healthy individual. That you can be outside of those ranges by a considerable amount and still be perfectly healthy and normal. That's important to remember. These are averages, these are baselines around which any given individual can go up or down. Now, a lot of our discussion of anatomical terminology is going to ground out around where things are found in the body. And that's going to include talking about, okay, where is one organ positioned relative to another organ? Is it above it or below it or to the left of it or to the right of it or that sort of thing? Now, when we're discussing that, we have to be talking about some positionality in the human body. We have to talk about what's a baseline position for orienting the body to understand this. And so we talk about a thing called anatomical position. Anatomical position is the kind of baseline reference posture of a human body for describing the location of things in anatomy. And when we're talking about where a body part is relative to another body part and saying, okay, this part is located above this part or below this part or to the left of this part or to the right of this part or whatever, we're assuming that positioning in a person who is in what we call anatomical position. So let me show you anatomical position so you know what I'm talking about. Let me just position my camera so I can show you anatomical position accurately. All right. I'm standing right now in anatomical position. I'm about as far back from my camera as I can place myself, but I hope everybody can see how I'm standing. I am facing the camera. I'm standing with my arms at my side. My palms are facing forward. Can't see this in my camera shot, but my feet are flat on the ground. Actually, let me lower the camera so you can maybe see a little bit better. There we go. Yeah, there's anatomical position better. Okay, so you can see me now. I'm in anatomical position right now, facing the camera. I'm facing forward. When you're in anatomical position, you are facing the subject. The subject is facing you. Feet are flat on the ground, toes pointing forward, arms are at the sides, palms are facing forward exactly like I am right now. Now, thing to consider about anatomical position. This is left, this is right. So when you're looking at a subject in anatomical position, you flip left and right around. In other words, when you are looking at an anatomical diagram, everything that is on the left side of the body will appear to be on the right side of the diagram. Everything that is on the right side of the body will appear to be on the left side of the diagram, because anatomical position assumes you are facing the subject looking at them, and therefore all of the orientations of body parts will be mirror image flipped. When you're looking at any anatomical diagram, assume you are looking at a diagram from anatomical position, and therefore right side body parts are on the left side of the diagram, left side body parts are on the right side of the diagram, unless the diagram says otherwise. If the diagram says, okay, we're looking from a posterior view, then left will be on the left, right will be on the right. If the diagram says we're looking from above or looking from below or some other angle, that's different. But otherwise, assume you're facing the subject like you're facing me right now. Now, when we're talking about anatomical position, sometimes we also have to divide the body up. Sometimes we talk about what are called planes of reference. A plane of reference is an imaginary line that cuts through the body at different angles for dividing it up into different regions. For example, we can talk about a transverse or horizontal plane. A transverse or horizontal plane is an imaginary line that cuts through the body across the midline, dividing it into top and bottom halves. We can talk about a sagittal plane. Sagittal, that word sagittal, has one G, two T's in it. A sagittal plane cuts through the body along a vertical midline, dividing it into left and right portions. We can talk about what is called a coronal plane. A coronal plane cuts through the body like this, dividing it into front and back portions. These are imaginary lines dividing up the body into regions for purposes of study. Now, if you're doing a dissection on an organ and you make an actual cut in an organ or part along those lines, we would say a section rather than a plane. So like later this semester, I'm going to give you brains to dissect, and I'll say, okay, make a sagittal section of your brain. And that means I want you to cut your brain down the midline into left and right halves. Or if you made a coronal section, you would cut your structure into front and back halves. If you made a transverse or horizontal section, you would cut your structure into top and bottom halves. Technically, you can make cuts along non-right angles. Anything that is a non-right angle is an oblique or plane or oblique section. But we don't use those terms as often in anatomy. Actually, I'm going to put some of these terms into the chat for you all real quick. Hopefully you're following along with my handout, but in case you're not, we have the transverse or horizontal plane, and that's top and bottom. We have the sagittal plane, and that's midline down the middle. We have the coronal. The word coronal means like a crown. That's dividing into the crown of the head, front versus back. That's also called a frontal plane. And then if you wanted to cut at any non-right angle, that's an oblique plane. So we sometimes use those planes of reference for just dividing up the body into like front and back regions or left and right regions or top and bottom regions for discussion. Now, let's talk a little bit about some parts of the body that have some distinct names that are important for discussion. Now, you know the names of a lot of body parts, but medically, some body parts have names that you may not know. I mentioned at the beginning of this discussion, just as a reference, that this whole thing I'm waving around right now is not all my arm. Medically, this is my upper limb. Medically, the arm is only the portion from the shoulder to the elbow. It actually has a formal medical name. That portion from shoulder to elbow, and I'll put this term in the chat, is called the brachium. Comes from the Latin word brachiate, which means to climb. You raise it up to climb. So brachium, shoulder to elbow. That is the arm right here. This part from elbow to wrist is the forearm. Forearm. Prefix for means in front of. And the official medical name of it is the antebrachium. The prefix ante means to come before. So literally before the brachium. This right here, your wrist, is the carpus, like when you get carpal tunnel. This whole thing, your hand, is the manus. You do things manually. It's the manus. And these are your digits. Anything digital, it's your digits. This digit right here has a special name. The thumb has its own special name. We number the digits, by the way, 1, 2, 3, 4, 5. So we can talk about the first, second, third, fourth, and fifth digits. But the thumb has its own name. It is called the pollex, Pollex. Similarly, your lower limb is not all your leg. Call the whole thing the lower limb, but it's not all the leg. The portion between hip and knee is the thigh. The portion from knee to ankle, that's the leg. The ankle itself is the tarsus. Anything tarsal has to do with the ankle. The foot has two different names, depending whether you want to use Greek or Latin. The ped or the pes. Like ped, like pedal on a bike, or like a gas pedal. Your toes are also digits. Fingers and toes are both digits. And you number toes, first, second, third, fourth, fifth, from biggest to smallest, just like you do your fingers. Your big toe has a special name, just like your thumb. Your big toe is called, sorry, I spelled it wrong in the chat. My bad. Let me fix that. Is called the hallux, Hallux. By the way, I should let you all know, it is important to spell things properly in anatomy. It is probably more important that you spell things properly in anatomy and medicine than in any other field you have ever taken. And the reason it's more important that you spell things properly in anatomy and medicine is because there are so many terms that are similar to each other that if you spell something wrong, you might spell something else correctly. And there are a lot of terms that are close enough that the spelling really matters. My favorite example, this word Putting this in the chat right now. Ilium, I-L-I-U-M, refers to the blade of your hip, the hard part of your hip that you put your hands on when you put your hands on your hips. This word right here, I-L-E-U-M, also pronounced ilium, is a portion of your small intestine that is located a few inches inside of your abdomen away from your ilium, your hip. They're pronounced exactly the same. They're located within a few inches of each other. The difference is one letter apart. Spelling matters, folks. My father-in-law recently discovered that he had not been getting coverage from the VA for 10 years for his hypothyroid. And he didn't know why. He had no idea why they wouldn't cover his hypothyroid until he discovered that someone had misspelled the term on the form and written down that he had hyperthyroid instead of hypothyroid. So they wouldn't cover his hypothyroid medication because his diagnosis was improperly listed as hyperthyroid. Spelling matters. A couple of other terms you should know. This area underneath the arm, the armpit, it has a name. Your armpit is called the axilla. A term a lot of people get wrong. When you hear about the groin is not the genitalia. The groin is the place where the thigh meets the trunk. What's the trunk, you ask? The trunk is the central mass of the body. It is everything between neck and groin. In other words, it's everything from here all the way down to where the lower limbs connect to the rest of the body. The trunk has three regions. There is the chest, which is also called the thorax. Chest is everything from neck down to diaphragm. Look at the spelling of diaphragm. It's got a PH in it and a silent G in it. Where's the diaphragm? The diaphragm is the sheet of muscle at the bottom of your rib cage. Whenever you breathe, the diaphragm pushes up on your lung, up and down on your lungs. So basically, the chest is everything from neck down to diaphragm, which is at the bottom of your rib cage. Below the diaphragm is your abdomen. Your abdomen is your belly. That's everything from the diaphragm down to the top of your hips. And below that is your pelvis. And the pelvis is everything from the top of your hips down to your groin. So those are the three regions of the trunk: chest or thorax, abdomen, and pelvis. That's the main mass of the body. By the way, when we're looking at the head, we've got the facial region. You know what that is. I don't think I need to explain that. And then you have the cranium. The spelling of cranium, N and then I. The cranium is all the parts of the skull that enclose the brain. Everything basically above the eyes and around here, all of that is cranium. Messed up my hair there. Okay. Your back has a name. It is called the dorsum. Everything that is on the back surface of your body, that's called the dorsal surface of your body. And your belly button has a name. Actually, it has two names. Example of a structure with two names. You've probably all heard it called the navel, with an EL, not an AL. AL is talking about the Navy. But the medical name of the belly button is it is the umbilicus, because that is where the umbilical cord attaches you to your mother while you are in her uterus. So those are just some names of body parts that you might not have realized. And we'll be using the formal names of body parts in class. When you hear me talk about an arm, know that I mean this, not all of this. If I want to talk about all of this, I will talk about the upper limb. Okay? Now, a big thing that we have to do with anatomical terminology, a thing we do all the time, is talk about directionality. Where are things located in the body compared to other things? Like, where do you find stuff relative to other stuff? Is something above another part? Is it below another part? Is it to the left of something or to the right of something? Is it closer to the midline, further from the midline? Is it above, deeper in the body, closer to the surface of the body? There's a whole lot of terminology related to positioning things relative to other things. And that's important both for describing where things are in the body and also for describing in medical situations where an injury might be found or where a pathology might be found. So we need to know directional terms. And there's a whole glossary of directional terms that you need to be familiar with that I will be using quite regularly in class. You need to familiarize yourself with them because you're going to hear them all the time. If you're following along with my handout, your directional terms are found on the third page of my handout. Most of these directional terms exist in pairs. There will be a term and its opposite. So let's go through some important directional terms, and I'll show you how they're used. So some of the ones you're going to hear most often. First off, anterior and posterior. I'm not going to go through them exactly in the order that they are in the handout. I'm going to go through them in pairs together. Terms anterior and posterior. When something is anterior to something else, that means it is closer to the front of the body. It is in front of another structure. So I could say, for example, that my breastbone, my sternum, is anterior to my heart. It is in front of my heart, protecting my heart. It is closer to the front of the body than my heart is. So it is anterior to the heart. The opposite term is posterior. So it is the heart would be posterior to the breastbone. So if something is closer to the back of the body or behind something else in the body, I would say it is posterior to it. So I could say that my breastbone is anterior to the heart is posterior to the breastbone, and then my spine is posterior to my heart. So I could go back like that. Make sense? There are two terms that mean the same thing as anterior and posterior. They're older terms that don't get used as much, but you hear them from time to time. The terms ventral and dorsal. If you ever hear the terms ventral and dorsal in anatomy, ventral means the same thing as anterior. Dorsal means the same thing as posterior. And you can use those terms the same way you use anterior and posterior, but most of the time these days we use anterior and posterior. Technically, ventral means towards the belly, and dorsal means towards the back. Those terms originated from anatomical dissection, from dissecting rats and other lab animals as study specimens. We don't use them as much in modern anatomy, but you hear them once in a while. Another pair of terms that we're going to hear quite a lot is superior and inferior. And this does not mean better and worse. This means above and below. So if something is superior to something else in anatomy, it is located above it. So my nose is superior to my mouth. And then my mouth would be inferior to my nose. So above is superior, inferior is below. Two terms that are older terms that mean basically the same thing is that when something is superior to something else, we could say it is cranial. When something is inferior to something else, we can say it is caudal. Technically, those words mean towards the head and towards the tail. Once again, these originate from the dissection of lab rats, and it's older terminology. You can still use it if you want, but it does not get used nearly as often in modern anatomy. We usually just say superior and inferior. Now, sometimes we're talking about how far things are away from the midline of the body. If something is closer to the middle of the body, we say it is medial to something else. Actually, let's do the pair here. Medial and lateral. If something is closer to the middle of the body, we say it is medial to something else. So I could say, for example, if I'm standing in anatomical position, that my lungs are medial to my arms. They're closer to the midline of the body than my arms are. If something is closer to the sides of my body, I would say it is lateral to something else. So, for example, I could say my lungs are lateral to my heart. They're to either side of my heart, they're closer to the outside of the body. Make sense? If something is right on the midline of my body, like my nose, I would say it is a median structure. Now, by the way, some structures in the body, this isn't really a directional term, but it's worth knowing. Some structures in the body are paired. If a structure is paired, I will say it is bilateral. My lungs and kidneys are bilateral. If a structure is only on one side of the body, like my liver, I would say it is unilateral. If two things are on opposite sides of the body, here's another pair of structures terms. If two things are on opposite side of the body, we say they are contralateral. So my left eye and my right ear are contralateral. There's a term that we will use later, this term called contralateral control. And that means that the left side of the brain controls the right side of the body and vice versa. If two things are on the same side of the body, we say they are ipsilateral. So my right eye and my right ear are ipsilateral structures. Now, sometimes we care about how close something is to the surface of the body. The terms we use here are superficial and deep. So I would say my skin is superficial to my muscles. My skin is on the surface, my muscles are further down. So I would say my muscles are deep to my skin. And my bone is even deeper. So my bones are deep to my muscles, and then my muscles are superficial to my bones, and then my skin is superficial to my muscles. So the deeper down you go, like the further into the body you go, the deeper you go, the closer to the surface of the body you go, the more superficial you go. Now, this is similar to, but not exactly the same thing as internal and external. If something is inside of another structure, we say it is internal to it. So I could say, for example, my brain is internal to my skull, and my skull is external to my brain. Now, if something is internal to something else, it is also deep to it. It's accurate to say that my brain is deep to my skull, you know. But not everything that is deep to something else is internal to it. When we say something is internal to something else, that technically means it's enclosed within it. We use the terms internal and external usually when we're talking about, okay, here's a compartment within the body that has something else enclosed within it. So sometimes there's overlap in when you can use particular terms. Now, here is an unusual set of terms. The terms proximal and distal, and it's easy to get confused about these. You only use the terms proximal and distal when you have a structure that has a clear starting point and a clear end point. And that usually means either something that has a point of attachment and then a free end, or a tube that has a beginning point and an end point. The proximal end is the attachment points or the beginning points. The distal end is the free end or the terminating points. So, for example, to illustrate this, here is the proximal end of my finger. Here is the distal end of my finger. Here is the proximal end of my hand. Here is the distal end of my hand. Here is the proximal end of my upper limb. Here is the distal end of my upper limb. So when I say something is proximal to another structure, I'm saying it's closer to the point of attachments. I have to define what I mean. So I could say that, my second phalanx, the joint of the finger, is proximal to the third phalanx, the third joint of this finger. It's closer to the point of attachment of the finger. This one would be distal to that uh, point of attachment. But if I'm looking at my upper limb as a whole, I would say that my finger as a whole was distal to my elbow. It's further from the point of attachment. And my elbow is proximal to my shoulder, comparing these two things. So remember, basically, when you're looking at the whole structure, this is the proximal end, this is the distal end. So if I'm looking at my upper, I'm making a Hitler salute there. I shouldn't be doing that. Okay. But let's try this. Okay. So if I'm looking at my upper limb as a whole, I could say, all right, my fingers are distal to my elbow. They're further from the point of attachment. My elbow is proximal to my fingers, closer to the point of attachment of the upper limb. Make sense? So you only use proximal and distal when you have a structure that has a clear point of attachment and a clear end point. I can also apply this to a tube, like a blood vessel or like my digestive tract. So I could say, for example, I'm looking at an artery, and I could say the proximal end of the artery is the end that's closest to the heart, and the distal end is the end that's furthest from the heart. Or I could look at my digestive tract, and I could say the proximal end of the digestive tract is the end closest to my mouth, and the distal end is the end closest to my anus. And I could look at any given point along there, and I could say, okay, the proximal end of the stomach is the end that attaches to the esophagus, where the food comes into it, and the distal end of the stomach is the end closest to the small intestines, where the processed food goes out of the stomach. So if you have any structure that's like a tube where things pass through it, the proximal end is where stuff comes in, and the distal end is where stuff goes out. So proximal and distal, always think about proximal and distal. You use those when any structure has a start point and an end point. And think about this with anatomical position, because if I'm thinking an anatomical position and I was looking at somebody like standing in anatomical position like this, people would naturally be inclined to say, okay, well, is my hand what's the position of my hand in anatomical position relative to my elbow? People would say, well, is your hand inferior to your elbow? No, my hand is not inferior to my elbow just because it's below it. I have a special term for that just because I'm in anatomical position. I've got a structure with a beginning point and an end point. I would say my hand is distal to my elbow because I'm dealing with a structure that has an attachment point and an end point. Always use the most precise term that you can. That's the rule of thumb. All right. Now, I'm going to direct you to a thing on your handouts that we're not going to really talk about in detail right now. And that is that there are many regions of the body that have descriptive adjectives for talking about them. That I want to say that there are two major regions of the body. We talk about the axial region. The word axial means like the main axis, like the midline. The axial region of the body refers to the head, the neck, and the trunk. And then we talk about the appendicular region, the appendages. The appendages would collectively be the upper and lower limbs. And then within those regions, we could talk about a lot of specific regions. And medically, you will hear a lot about specific regions of the body. Like you might say, okay, my patient has pain in the lumbar region of the back, which is the lower back. Or my patient experienced an injury in the scapular region, which is right around the shoulder blade back here, or in terms of the limbs, you might say, okay, my patient is having, pain in the cubital region. That refers to the elbow, or the patient is experiencing calcaneal sores. The calcaneal region is the region around the heel. I am not going to go through the entire glossary of all of the regional areas of the body with you right now. There are numerous regional areas of the body. If you look at the third through fifth pages of your anatomical terminology handout, you will see a glossary of regional terms for specific areas of the body. Please look over them. I'm going to start using these terms in class. Whenever you do an exercise, once you get your lab handouts, the ones you're going to do exercise and mapping out the regions of the body and learning about them. But it would be extremely tedious for me to sit here with you right now and just go through a list of several dozen regions of the body and say, okay, right here is the mental region, right here is the nasal region, right here is the zygomatic region. We're not going to do that at the moment. But please read over those and be prepared for the fact that when you're going to get an assignment about them, you're going to start mapping them out, and I am going to start using those descriptive regions for the body in class sooner rather than later. Now, what I do want to talk about is when we get into the interior of the body, when we start looking inside of it, there are a couple of important ways we discuss what's going on in the interior of a human body and some things you need to know about what's going on inside of it. Those things I was talking about, those are external surface regions, like I can say, okay, here's the antecubital region, which is the region of the forearm, here's the cubital region around the elbow, et cetera, et cetera. But we get into the inside of the body. Some important regional terms you do need to know that I want to talk about for a few moments. Inside of our bodies, you're going to find several distinct spaces or cavities where your internal organs reside. Those spaces are going to all be lined with various wet membranes that protect those internal organs and line those cavities. You have two kinds of membranes you find inside of your bodies. We have what are called mucous membranes, and you have what are called serous membranes. Now, a mucous membrane, and please note the spelling of mucous membrane. Mucous. That is a kind of membrane. That's an adjective. Mucous. A mucous membrane is a membrane that makes a sticky fluid called mucus. That fluid is spelled mucus. There's no O in the fluid name. The type of membrane, mucous. That's an adjective describing a kind of membrane, has an O in it. The fluid it makes, mucus, does not have an O in it. Mucous membranes protect openings to the body is the usual place you will find them because they make a sticky protective fluid that is largely there to trap foreign particles that would get into the body. You will occasionally find mucous membranes in other places as protective fluids. The digestive tract has a lot of mucous membranes because it has to protect itself from its own acid secretions. Anyways, you have to guard against an acid secretion, you're going to find a mucous membrane. So where do you find mucous membranes? Wherever there's an opening to the outside environment where bacteria and foreign particles might potentially enter the body and where sticky mucus can trap them and prevent them from getting further. So you find mucous membranes in the nasal cavity, in the oral cavity. You find mucous membranes forming the lining of the respiratory tract. All of your respiratory passageways going down into the lungs have mucous membranes. You find mucous membranes going down into the digestive tract, forming the lining of your digestive passageways. You find mucous membranes in the anal canal, because that's a wet membrane that goes to the outside. You find mucous membranes in the vaginal orifice, because that's an opening to the outside where bacteria can get in. You find mucous membranes in the urethra, in the urinary tracts. All of these are places where there will be a wet mucus coating that can potentially trap foreign particles that would get in from the outside. Now, the other kind of membrane we have in our body would be serous membranes. Serous membranes, which are sometimes collectively called serosa, mucous membranes are sometimes called mucosa. Serous membranes are going to produce smooth, lubricating fluids. You will often find them coating the inside of body cavities that don't have an external opening. You'll find them coating the surface of organs to prevent friction between organs inside of body cavities. They will secrete lubricating fluids inside of your body cavities to provide fluid cushions, protecting those body cavities and those organs from harm. You will find serous membranes lining ducts and tubes inside of your bodies, like blood vessels and lymphatic ducts and kidney tubules. Basically, any place where there's an internal cavity or duct in your body that does not have an external opening, you're going to find a serous membrane covering it, lubricating it, and producing a lubricating fluid to protect against friction from other bodily sources. And most of your internal bodily organs are covered by a serous membrane. Now let's talk for a moment about those body cavities, the spaces in the body where stuff resides. Now there are two main compartments in the body. We can talk about the dorsal or posterior body cavity and the ventral or anterior body cavity. Now, the dorsal or posterior body cavity is subdivided into two smaller cavities. There's the cranial cavity. The cranial cavity is the space inside the skull where the brain resides. And there is the vertebral or spinal cavity, the long, narrow cavity formed by all of your vertebrae that goes down the length of your spine where your spinal cord resides. Both of those cavities are connected. They're filled up with a liquid called cerebrospinal fluid. You might have heard of that before. We'll talk about that more when we talk about the nervous system. And they are lined with protective membranes that you might have heard of called meninges, which you can get infected and you can get a thing called meningitis. Now, the ventral cavity or anterior body cavity is the main central cavity of the trunk of your body, where most of your organs reside. Now, the ventral cavity of your body is divided into two smaller spaces, separated by that sheet of muscle we call the diaphragm that we mentioned earlier. And those two smaller spaces are the thoracic or chest cavity. The thoracic cavity has two smaller compartments within it. Well, actually, three smaller compartments if you want to be technical. It has the two pleural cavities. Note the spelling of plural, Pleural, left and right pleural cavities, which house the lungs. The pleural cavities are lined with serous membranes called the pleural membranes or pleurae. By the way, a common thing you should learn in anatomy. Not everything is pluralized the way you would expect. In the English language, we pluralize things mostly by putting an S or an ES at the end of them. In anatomy, we pluralize things using Greek endings very often because so many of our words come from Greek. And in the Greek language, there are more than two ways to pluralize a word. The Greek language has a lot of ways to pluralize words. And it all depends on the different kinds of word endings, but Greek has something like 15 different ways to pluralize a word depending on how the word ends. And we're going to use a lot of those in anatomy. So sometimes when I give you the plural ending of a word, it's going to be non-intuitive relative to what we know in English. But in medicine, we use a lot of those. And one of the very common ones you're going to see is that in medical terms, if a word ends in A, the way you pluralize it is by making it A-E at the end. So if a word is pleura, the proper pluralization would be pleurae, A-E. So you're going to see that one a lot. I'll let you know if there's a weird pluralization that comes up in here. It's going to happen frequently. But so they've got the two pleural cavities within the chest cavity. And then between them, right here, there is a third space within the thoracic cavity, within the chest cavity, called the mediastinum. The mediastinum is the cavity between the pleural cavities. It's the cavity where the heart resides, and where also a gland called the thymus resides, right above the hearts. That's your cavity where you're going to find the hearts. Sometimes you'll hear the term pericardial cavity for the compartment where the heart resides inside of there. Now, beneath the diaphragm, you'll find the second part of the ventral or anterior cavity of the body, which is called the abdominopelvic cavity. Now, as you can probably guess from the name, the abdominopelvic cavity has two spaces within it. The abdominal cavity. This is the abdomen. The abdominal cavity is going to be the main cavity of the belly, occupies right around where you put your hands, where most people would say is their stomach. Technically, it's the space right below the rib cage, contains most of your digestive organs. Your kidneys live there. Your spleen lives there. And then right below that, we find also the pelvic cavity. And the pelvic cavity is the cavity surrounded by your hips. The pelvic cavity is where we find your bladder. It's where we find your rectum. And for female-bodied persons, it is where we find the internal female genitalia, the uterus, the ovaries, and the fallopian tubes. There are a few other body cavities I should mention. Smaller ones that are not attached to those big main body cavities. You have the orbital cavities right here in the anterior of the skull that house the eyes. You have the nasal cavity, the space posterior to the nose. The oral cavity, the space posterior to the mouth. You have smaller spaces inside the skull that are called the paranasal sinuses. I put that term in the chats. We'll learn more about them when we learn about the skull and the respiratory system. You have the middle ear cavities housed inside the bones of the skull, where your apparatus for your senses of hearing and equilibrium are found. And housed in numerous parts of your body, you will find the synovial cavities, which are the joint cavities, the fluid-filled cavities associated with all of your various flexible joints. And we'll learn about those when we talk about joints and movement later this semester. In addition to all of those cavities, numerous internal organs, as well as all of the various ducts and tubes in your body, like blood vessels, will have spaces inside of them. So you have, for example, the space inside of your stomach, the space inside of your colon, the space inside of your bladder, the space inside of every artery and vein in your body. Those spaces, those cavities, are called lumina. The singular, if you're talking about just one of them, this is another great example of a weird pluralization. If you're talking about just one of those spaces, it is called a lumen. So the space inside of your stomach is the lumen of the stomach. The space inside of an artery is the lumen of that artery. And if you're talking about more than one lumen, the plural is lumina, which I always thought was kind of a pretty word. So if you've got a Greek word that ends in en, you pluralize it by making it ina. One lumen, multiple lumina. Now, I talked about the abdominopelvic cavity just a moment ago. Before we leave that behind, I have one odd little thing I need to share. And this is kind of a medical and surgical, in some ways, thing I want to describe. And I'm going to share a diagram on the screen here for a moment. That in medical contexts, and also for describing where things are found in the abdominopelvic cavity, there are ways that this cavity is divided up, medically speaking. That there are two different ways that anatomists and physicians divide up the abdominopelvic cavity for descriptive purposes, for purposes of saying where things are found within it. And here is the diagram of the abdominopelvic cavity divided up two different ways. And this is straight out of my anatomical terminology handout, so you can reference this diagram later. The easy way is to divide it into quadrants. And you have a left upper quadrant, or LUQ, a right upper quadrant, or RUQ, a left lower quadrant, or LLQ, and a right lower quadrant, or RLQ. And you can see kind of the cutaway image here of where some important things are found. Like, for example, in the left upper quadrant of your abdominal cavity, that's where the stomach is localized. You'll find the stomach and the spleen over there. The right upper quadrant is where you're going to find the liver and the gallbladder. The left lower quadrant of the abdomen is mostly where you're going to find intestines. Right lower quadrant has intestines, but also the appendix is located there. So that's where you're going to find the pain from appendicitis. A more precise mapping for locating specific organs and for localizing pain and injuries and so forth for surgery and pathology and so forth is to divide it into this 9-square grid, like a hashtag, where we can go across the top and we can have the right hypochondriac region, the epigastric region, and the left hypochondriac region. And let's talk about those terms for a minute. Hypochondriac. The word hypochondriac people use to say somebody who thinks they're always sick. In this context, hypo means below. Chondriac, chondro means cartilage. Hypochondriac, it means below the cartilage that binds the ribs to the sternum. So hypochondriac region. Epigastric, prefix epi means on top of. The epigastric region right here in the middle of this region, it's above the stomach. Epi means on top of, gastric having to do with the stomach. And then the left hypochondriac region. We have below that, the right and left lumbar regions, because this is right around the lower back. And then in the middle, the umbilical region for your umbilicus, your belly button. And then we have the right and left iliac region for the ilium, the blade of your hip. And then below that, the hypogastric region, which means below the stomach. I mean, the stomach's a good bit above that. There's more intestines and so forth in the region, but I had to give it some kind of name. And so this is a somewhat more precise way of dividing up the abdomen for the sake of describing where things are. All right, folks. This has been a kind of a quick and dirty preview of anatomical terminology. There are a lot of very precise and specific terms that we could get into in here with the regional terms that we did not get into, which I urge you to, again, to begin studying those. We'll be doing a lab activity related to those in class. We'll start analyzing those more particularly. But this has been at least an introduction to some of the language and specifics of anatomy and physiology. This is language that you will be getting into in more detail in class. The best way to learn it is by using it. You'll be seeing it in your text readings. I'll be using it in our lectures. And you need to begin thinking in these terms, because this will be the entire language, not only of this class, but of every other medical type class you take, and indeed of your profession going forward. If you were taking any class for which, going to any field for which anatomy and physiology is needed. And these will be terms that you will be seeing on your first quiz in here as well. So thank you very much. I will see you all in our next class. Take care.